Welcome, everyone. I see we have some attendees joining us now. While our attendees are joining, I'll just get the show rolling and introduce myself in the meantime. I am Sasona Buyeye, and I am the Communications Coordinator at Ibis Reproductive Health, and I will be a facilitator for today's webinar. So the theme of today's webinar is Informed Choices, Healthy Futures, which seeks to emphasize that young people have a need for access to medically accurate sexual and reproductive health and rights information that helps them make informed decisions about their health and their well-being. World Sexual Health Day is observed annually on this day on the 4th of September to promote the awareness of sexual and reproductive health and rights worldwide. Globally, a mass attack on reproductive health rights threatens to undo decades of work done to guarantee a set of rights for women and girls and their well-being. Despite progressive laws and policies safeguarding young people's access to SRHR services in South Africa, including family planning and abortion, many adolescents and young people continue to face significant barriers. Now, before I introduce our speakers for today, I would like to invite you all to complete a short survey just to learn more about your thoughts on today's topic. And I will share the link in the chat as well as a QR code that you can scan. Just quickly do that. Okay, I have shared a QR code to my screen. You can scan that QR code or click the link in the chat and just fill in that survey. I will give everyone about 5 minutes. We will continue with the program at around 8 minutes past 3, just to give everyone some time to complete the survey. If you are still completing the survey, you can continue to fill the form. In the meantime, I will introduce our speakers for the day. Up first, we have Tshepo Ngwato, a South African youth advocate, leader, and human rights activist who currently serves as the director of the Y+ South Africa Network, duty person of the human rights sector in the National Civil Society Forum, chairperson of COP, a youth-led movement coalition that addresses the intersection of climate change and sexual and reproductive health and rights. As one of the first generation of young people born with HIV in South Africa, Tshepo turned his lived experience into a platform for advocacy, co-founding the Y+ network to support young people living with HIV across all 9 provinces. His work focuses on breaking stigma, advancing treatment literacy, and ensuring that young people's voices are meaningfully included in policy development. Recognized for his regional leadership, Tshepo continues to drive advocacy that links SRHR, climate justice, and human rights, positioning youth as central actors in shaping equitable and sustainable policies across South Africa and beyond. Our next speaker will be Dr. Enau Our Georges Stevens, MD, MPH, PMD, ABS, with over 10 years of experience in program design and implementation on sexual, reproductive, maternal, newborn, child, and adolescent health. Based in Cameroon, Enau manages advocates for youth's Amaze International work in sub-Saharan Africa. In this capacity, he cultivates organic and strategic partnerships at regional and local levels, providing technical support to partner organizations on youth sexual and reproductive health programming, with a focus on sexuality education, use, adaptation, and dissemination of Amaze digital resources and meaningful youth engagement. Prior to joining Advocates for Youth, Enau served as a physician in obstetrics and gynecology department, managed youth sexual and reproductive health programs, and provided technical support on sexuality education, family planning, reproductive health, HIV prevention, quality of care, learning resource package development, and the transfer of learning in emergency and post-conflict settings in sub-Saharan Africa. Enau led the youth and comprehensive sexuality education work in the Africa region at IPPF, where he provided strategic and technical guidance to IPPF programs and IPPF programs in comprehensive sexuality education and youth sexual and reproductive health and rights design and management. Thirdly, we have Judy Ranape as a comprehensive district health nurse trainer and abortion provider with the Southern Western substructure of the Department of Health in Cape Town, South Africa. She serves on the Women and Child Health Forum and the Gender Affirming Healthcare Advisory Group. She trained as a nurse at Coronation Hospital, now Rahima Musa Mother and Child Hospital, and specialized in critical care nursing at Anne Latsky Nursing College. She holds a BTech in primary health care from Cape Peninsula University of Technology and a master's degree in nursing education from the University of the Western Cape. A reproductive justice advocate, Judy provides first trimester medical and surgical abortions under the Choice on Termination of Pregnancy Act, serving vulnerable women, girls, sex workers, and LGBTQI+ communities. An award-winning leader, she has been recognized nationally and internationally and is currently a Global Atlantic Fellow for Health Equity at Degano, South Africa, advancing equitable healthcare for rural and marginalized communities. Our fourth speaker, Motlatsi Komote, is the head of research and programs at the Campaign on Digital Ethics, also known as CODE, who provides strategic leadership and oversight for research and programmatic activities related to digital ethics. Over the course of her career, Motlatsi has dedicated herself to the fight for human rights and good governance in South Africa. In this regard, she has previously served as the chairperson of the Budget Justice Coalition and currently serves as the chairperson of the Sakhi Bartman Center for Women and Health and Children. Lastly, but not least, Kuliso Managa is an attorney at the Women's Legal Center based in Cape Town and works in their sexual and reproductive health rights focus area. The Women's Legal Center's SRHR program focuses on ensuring that women are able to access sexual and reproductive health services in a manner that is non-coercive and free from violence and all forms of discrimination. We understand that accessing reproductive health care can be a complex and confusing task for women, and that this has an impact on a woman's ability to make informed and autonomous decisions about their health care. There are also very few accountability mechanisms within the state healthcare system, so they take on projects and cases that promote and protect a woman's right to make choices about their own reproductive health and litigate to ensure that women have fully realized access to reproductive health care. Now that we know a little bit more about our speakers, we just have a few housekeeping items. If you have any questions or comments, you may use the Q&A feature to submit them. We will then have a Q&A session after the presentations, during which we will answer the questions. And without further ado, I will now hand over to our first speaker of the day, Tshepo Ngwato, who will speak to the insights on the lived experiences of young people and the challenges they face with accessing SRHR services.
Hi, how are you? My name is Tshepo. I am from a youth-led organization called Y Plus, and we strictly serve on youth matters, entirely young people living with HIV, and looking at the promulgated laws that are within South Africa. But I think, there's also one thing that most people don't have to understand, that in South Africa, South Africa is celebrated for having one of the most productive policy environments in Africa, which comes to sexual reproductive health rights and strong laws on paper. The reality for young people looks very different and entirely when you look at issues or barriers that they face and the needs and gaps between the law and policies and practices that are actually being practiced here in South Africa. Looking at one of the legal frameworks that we will look at is like the legal access to contraceptives, mostly for when you're looking for adolescents. They have a choice for termination, which is within the Termination Act of Pregnancy. Allows for safe abortions, legal abortion under the definition of conduct. And also looking at the right-based approaches, recognizing young youth rights and health rights and their dignities, which South Africa has led to have a strong legal foundation when young people can entirely have access to those services. But the policies the policies that entirely align with the international human rights standards and ensuring that sexual reproductive health is actually there for young people. But the access is not about the laws alone. It also depends on how services are being delivered. Mostly when you look at communities, are they entirely delivered properly? How informed are young people about these services? And when you look at entirely about the disconnect between laws and reality, the production frameworks do exist, but yet the barriers in proactive are actually one of the things that young people entirely face on a day-to-day basis, where us as activists have to also go all the time and try and advocate for social issues, mostly looking at the disconnect between what the laws provide and what young people are actually experiencing on a day-to-day basis. And can you hear me?
Yes, we can.
Oh, okay. Um, Entirely when you speak about young people, we should be able to walk a young person should be able to walk in a health clinic and receive care without fear, reality, and mostly are denied services. And some are misinformed and some are judged. Pertaining when you look at young people who wanted to go and get health services, and some are entirely judged by entirely health workers where some actually do fear to go to a health facility because of the someone that they know who works at the health facility and cannot be able to get those services. Where also another issue when you look at families and communities, that disbelief between that is please so this actually creates fear and shame amongst young people, and basically it's a stigma and is one of the biggest strongest barriers that young people are turned away and treated with the disapproval when they seek abortions. And here's also another thing that for the past decades within families, the young people have been stigmatized. Normally, when you look at young person that just found out that they are pregnant, they want to go and have abortion. We have to look at some of the things of family values because people that have got family oriented issues of you can't do an abortion. You don't have your rights to do that. I've got the approval. If you don't, you'll be chased away from the house. And it's just one of those things that we really need to step up and look at some of the things and have informal of education amongst our parents and also health workers and actually ensuring that the community entirely understand about the rights of a certain young person that they can be able to get on a day-to-day basis. So we need to be able to create a culture where we demolish the silence around where young people literally get their services and they can freely walk into a health system and be able to get their services. And I think it's also one of the things that um, young youth services are not being rendered properly. I'll talk about one of the things that in South Africa, we were supposed to be having a youth health spaces, which is one of the things that we have been literally been advocating for the past decades now. And entirely when you look at the youth health spaces, it's just centralized on providing smaller services, but not having your services being run by young people themselves. For example, I can't literally go to a health facility and literally talk to a nurse that's older than me because I don't feel comfortable. I need a nurse that can literally talk to the same age as me because if I get someone who's around their 50 something, who is not yet retired but still a health practitioner, there's a sense of disconnect when it comes to such because you can't entirely speak freely about that. That's why when you get to a young person going to a health facility, when the young person, when you ask him, are you drinking? Do you do 1, 2, 3, 4, 5? They'll tell you that no, I don't do that. But in the background, they know that they actually do those things. But that's why you will end up not getting the real information that you need from a young person. And sometimes a young person will literally tell you that the person is not sexually active. While at the same time, that young person is sexually active, but you wouldn't know because you are not in their footsteps on a day-to-day basis. I think we really need to create a barrier of having young people to be able to feel comfortable, to be able to walk in a space and feel safe that, you know what, I'm here to receive something that can literally render me my services. Um, and now moving slowly into communities. Within communities, within communities, there's a lot of sense of misjudgmental that goes around. Also having these posters that are actually going around and being posted. And if you go to the central CBD, you'll literally see a poster that says abortion. And now you entirely encourage a young person to literally have a backstreet abortion and entirely say that, you know what, it's safe for them to go there. And no one is saying anything, and we are literally quiet about such. And no one is literally walking in the footsteps and saying, but A, B, C to Z, why aren't you literally stepping up and cleaning up this mess that you're doing? Because young people are literally being abused in this case. And literally, it's actually a violation on its own, because we've got facilities which are not even registered, and they're actually providing this type of services to entirely young people who are looking for help, but they are not providing them with proper services. Yes, then you have to look at issues of within communities where that young person, for them to literally be pushed to such, is because of barriers within the house. They'll tell you that you can't do 1, 2, 3, 4, 5, and they end up going it in the backstreet abortions, or otherwise they go to a health facility. There's that certain nurse or doctor or a health practitioner who literally is ready to literally judge that young person, and literally that encourages a young person to look at those backstreet abortions. And now looking at, I think we really need to informally educate young people entirely about education, about their treatment and the treatment that they're drinking. For myself, I can literally tell you, I've been living with HIV for 32 years, but during the courses of that, they have not been that verge of had young people that they know the treatment that they're drinking. There are certain young people who don't even know TLD. There are certain young people who are still stuck and saying, TLD is the same, etc. TLD is just different. So there's that certain miscommunication that immediately once you find a young person or a certain young person who's just been enrolled in a health facility, they immediately don't actually get that provision on understanding that this is the type of medication, what is it for, etc. How do you keep yourself fit? We actually only focus of enrolling young people into a health facility, and just actually they don't even think about the after effects that will literally come to that young person. And without further ado, we really need to stop the issue of speaking on behalf of young people. I think I want to put it straightforward, because at times we end up missing the miscommunication and replicating something over and over again of having a young person being in a space of health. Then they end up miscommunication of that young person received the certain services that they always need. But if you're a health practitioner who's out there, the only thing I think we really need to encourage and try and be more friendly to that young person who's there, and be able to train the health provider to be able to be more comfortable and respectful and not judgmental to that young person. So we need to actually also establish a more friendlier and more established youth-friendly health services across the whole of health facilities, no matter how small it is. But young people really needs to be encouraged to use those facilities, and those facilities need to be run by young people. I do understand some people will be concerned, but there's no funding for such. At times, we can look at how to integrate some of those health services with the existing platforms. For example, the only thing you just need to get yourself a container and have those provisions for young people to lead it. There's always a certain of young people who are actually working in those health services, or otherwise we provide training to those certain individuals who would be rendering services to young people. And also, again, I think we really need to look at the CSE education, which it really needs to be fully implemented across age appropriated. From my side, I feel like because the first time when we started advocating for such, started advocating for CSE, we had faith-based leaders who were actually against this because they feel like young people will literally start having sexual intercourse. But when I look at it, is a certain information that they are failing to be able, as a certain parent who's failing to actually educate the young person about their health matters and be able to educate, like you go to your home, but you're failing to talk about with your child about health issues. That's why your child will end up going outside and getting that information, which is misinformation at the same time. Then they end up coming back. You are going to shout them for your mistreatment of how the child is being raised in the house, and you feel you're going to end up feeling like a failure. Um, Without further ado, please let's empower the youth policies and actually look at, we've got the best policies, but the actions are actually not working. We really need to start implementing the things that are written in the policies, because we've got the National Development Plan, which looks at young people for employment, for etc. But when you look at the things that are supposed to be done, that they are not meeting the targets of young people. And from now on, let's stop talking about saying that young people are the future of tomorrow. There's no tomorrow. The tomorrow starts now. It's today, because at the end of the day, you can't be speaking on young people and relying that they are tomorrow while you're still in the leading in that platform and not making ethical changes for the health services. Because we are going to 2030 and it's not a reaching pertaining the SDGs that we are trying to reach as a country. And right now, we really need to take critical actions and really pushing for the agendas of our youth issues. Like right now, we've got extremely violences in schools that are actually raging, extremely skyrocketing, but no one is saying anything about that. There's no social behavior changes programs that are actually enrolled in health school facilities. You literally see a student actually going and actually stabbing or bullying a teacher, or maybe they're bullying each other, but there's no programs that are looking at healthcare school facilities, because at the end of the day, we can't literally even access school facilities because there are always clause of the SGBs that are actually in line. And the SGBs are actually the parents who are actually doing such things, meaning that we are failing young people if you're literally looking at it in an instant. But I think in closing, let's work together and really achieve the needs of young people. Over.
Thank you, Tebo. Thank you so much. I really like what she said. Tomorrow starts now. Thank you for sharing your insights. And just a reminder to everyone, if you do have any questions for Tebo and for any of our speakers, just to submit them in the Q&A box. You will see it at the bottom of your Zoom screen. It is a question mark inside of a speech bubble. If it's not in your immediate notes, just click more and you should see it there and submit your questions or any comments that you may have. And without wasting any more time, I will now hand over to Dr. Enau to speak on the importance of comprehensive sexuality education and its contribution to educating young people about their reproductive well-being. Over to you, Enau.
Yeah, thank you very much, Sezona, and hello, everyone. Always a pleasure to speak on this topic around CSE. And thank you very much for selecting this topic for my presentation. And I would really focus around how CSE can really contribute meaningfully to educating young people about their sexual and reproductive well-being. And I also want to use a case study of a maze. But first, I just want to bring us back to what CSE is, because I know that in most countries in sub-Saharan Africa, CSE is always the terminology CSE can be a problem. Now, we know that CSE is evidence-based education, but for CSE to be CSE, it must be age appropriate. That means that it must really align to the age group of a particular individual. It must be scientifically accurate. It means that it must be a fact. And then it must be culturally relevant. So for CSE to be CSE, we must make sure that these three boxes are being ticked. And so CSE really provides evidence-based education about sexuality, relationships, consent, reproductive health, and rights. But to me, what's really important is not only about the information, it's also about empowerment. It's also about character change. Because most of the times, many people or parents or adults or stakeholders think that when we talk about CSE, we're talking about sexualizing young people. But it goes far beyond education. It's a mindset change. It's a behavioral change. It's empowerment to young people to make informed decisions and also protect their sexual and reproductive health. Now, in Africa, most young people have a lot of challenges when it comes to CSE, from stigma and cultural taboos around sexuality to limited access to accurate medical information to misinformation. Now, there's a lot of misinformation either from our peers, from the media, or from social networks, but also barriers to contraception. In most of our African countries, young people cannot freely go to the pharmacy to get a condom or to get a contraceptive device, or to even access SRHR services. As a clinician, most of the times when a young person comes to me, with a vaginal discharge, they'll first of all come telling you they have a headache. But the headache does not bring them to the hospital. After consultation, would you realize that they actually came because of an abnormal vaginal discharge? Why is it so? It is because there is still stigma and a lot of barriers for young people to access SRH services. Why must our young people suffer? SRH is not just for the old, it's also for the young. And so despite these progressive policies that most countries have, young people still face a lot of social and structural barriers. And this has a lot of negative consequences on young people. For example, just a simple error, having unprotected sexual intercourse with an HIV positive individual can lead you to contracting HIV. It could be you getting a teenage pregnancy because you didn't know about the different methods of preventing conception. So these are very small mistakes that could lead to serious problems. And if young people are not aware of this information, they're not educated. If they don't know, definitely they will not be able to make informed decisions. The reality is that we cannot talk about young people without talking about comprehensive sexuality education. All starts from there. And so our CSA needs to be specific, scientifically accurate, and culturally relevant. Now, this is what we do at Amaze. What we do is that we develop content for young people around comprehensive sex education. Give it any name you want to give it. I know in Zambia, you will say life skills. In Cameroon, they would say holistic sexuality education. Give it any name you want to give it, but educate young people around their sexual and reproductive health. It is important for this information, for this education to be youth-friendly. And of course, as I said, for it to be culturally relevant. So that is what we do at Amaze, where we develop content for young people in an age-specific manner, which are culturally relevant and also which is scientifically accurate. We develop short content, animated videos to explain topics around different around sexual and reproductive health, for example, puberty, consent, HIV, and what have you, to young people within the African continent and globally as well. And we've reached over millions of young people through this content. But what is really of interest is the impact of Amaze on CSE content, because when we do so, we increase knowledge about reproductive health and rights. I spoke about reproductive health, and I also wanted to touch the rights aspect because it's also important for young people, especially those in conflict-affected areas. We've improved the attitudes towards contraception, HIV prevention, and healthy relationships, because CS is also about attitudinal change. At times, young people have a wrong conception about what contraception is all about, what HIV prevention is all about, and what healthy relationships are all about. And so through this content, young people are able to improve their attitudes, what they think about contraception, what they think about HIV prevention, and healthy relationships. We've had a lot of youth testimonials highlighting their empowerment and confidence in making decisions. A no is a no, a yes is a yes. Consent is very important. And so as a young person, if you cannot have adequate information about CSE, there is no way you can confidently make a decision. Once you have information, you are able to make a decision because knowledge is power. And so if you don't have that knowledge, it will be difficult for you to make an informed and confident decision about your sexual and reproductive health. So for young people to really feel supported, to really feel empowered, they must have this information at their disposal. They must have this education at their disposal, regardless of where they are. Young people, or CS does not only touch young people in urban settings. There are young people in rural settings. There are young people in conflict-affected settings. There are young people from different groups, because young people are not a homogeneous group. Young people are very diversified. There are young people living with disabilities. There are young people from the LGBTIQ community. There are young people living in conflict-affected settings. There are young people with mental health issues. Young people vary from age to age, from group to group, and in different diversities. And so CSE must touch all these aspects of young people for us to be able to have young people who are empowered, because empowerment means getting the right information. Now, what lessons have we learned moving forward? We have noticed that for CSC to be effective, it must be localized. We must have a buy-in of our context, of our local community. CSC must be localized. It must be culturally relevant to suit the realities of young people in a particular context. It is true, we might say that young people in sub-Saharan Africa have almost the same challenges, but there are still some differences. What young people in Cameroon face might be different from what young people in Kenya are facing as far as CSE is concerned. And so that is why there is need for cultural relevance. Also, we must harness the power of digital technology. We must use different platforms to deliver CSE. I know back in the 10 years, 20 years ago, we used to leverage on CSE in the class, to teach young people, CSE in classrooms, CSE in school. But now we are seeing that digital CSE also has a great and critical role to play because young people are online. There's also CSE out of school because we've noticed that most young people are not in school. Some don't even go to school. And so we must also reach out to these young people who are not only out of school, but who are online, but who are in the communities, who are going to the farms, who are doing menial jobs. All of these young people also need CSE. And so we must diversify the platforms through which young people are getting education about CSE. Most of the time, some young people even, learn from their peers, even from their peers, from social media or from different networks. Are this information scientifically accurate? Do this information which young people get, are they accurate? Are they misinformed? Are they myths which they use to take as reality? Some of the times, the information they get is not accurate. And so that puts them in danger, at risk of making the wrong decision. Last week, about 2 weeks ago, just getting a 19-year-old girl who came to me and she was consulting. And her question was, if she stays as a virgin for till about 29 years old, will there be any negative consequences on her reproductive health? Because she has peer pressure from her friends to indulge in sexual activity. Just one strong information from a peer can make that young person get into problems. Just one wrong information. So there is need for us to diversify the platforms through which young people get CSE education. It's very important. We've also learned that there is need to monitor and provide feedback around how effective our programs are in these different communities. It doesn't always suffice to provide education around CSE to young people, but to monitor, is this working? What can we do differently? How can we make sure that this information, this education we are providing to young people is accurate and it's effective? Are we getting feedback from young people around CSE? Very important. Now, we've also noticed in terms of recommendation for scaling CSE at community, at country, and at regional level, there is the need to collaborate with local partners for contextualization. And that's what we do at Amaze, because we notice that we cannot go far if we don't collaborate, if we don't come together, if we don't connect the dots, if we don't build partnerships at local level for contextualization. It's very critical. There is no way we can bring information from Kenya to suit South Africa. It doesn't work like that. We must make sure we collaborate with local partners at country level, at community level, for the contextualization of comprehensive sex education resources. We must leverage on digital and social media to expand our reach. Because as much as we are trying to educate young people, that is how we also have misinformation about different CSE issues. And so we must leverage on every digital and social media network. It's important. Also, we need to use storytelling because we've noticed that storytelling has become very important, impactful for young people. When someone tells their story, what they have gone through, it provides a very strong ground for attitudinal change. personal testimonies around the different use of CSE resources, but also interactive formats, with young people to be able to combat these myths which young people are facing on a daily basis. As a matter of fact, as a young person growing up, there is no way you want to cross your 20s, your 30s without talking about CSE. Now, it's also important for us to integrate CSE into both formal and non-formal settings. By formal, I'm talking about schools, and non-formal community or online settings. Because as I said, not every young person is in school. Some are in the community, some are online. And so we must harness the power of technology to be able to talk about CSE, to talk about sexual and reproductive health and rights. We must look at the rights component. How many young girls have been silenced from rape, from harassment, from exploitation? How many young boys have been silenced from rape, from harassment, from exploitation? How many live with this trauma their lifetimes? How many? There are countless of them because no one gave them a voice, because no one showed them their right, because no one empowered them to say, this is what you have to do when you face such a challenge. I think it's high time we touch all these aspects if we want to scale CSE, if we want young people to get this education, because CSE is a very powerful tool. It's an important tool for promoting reproductive well-being. We are talking about the World Sexual Health Day. Sexual health is not only about having, pleasurable sex. It's also about safe sex. It's also about safe ideas, ideologies about sexual and reproductive health. And so what we do at Amaze Africa is really that we demonstrate that youth-focused digital-first approaches can really make CSE accessible, engaging, and impactful. So young people must be empowered because those who are empowered are likely to make informed decisions. They'll reduce their risk and they'll advocate for their rights. They will know what is correct. They will know when to come and say, no, this is not correct. No, this is my right. I have the right to access contraception. I have the right to say no. I have the right to give my consent. I have the right to educate myself. I have the right to know my body. I have the right to know every part of my body. I have the right to have pleasurable sex. All those things, we hide them from young people. And when we hide them from young people, they tend to make wrong decisions. I always say this. My father always tells me, knowledge is power. Knowledge is empowerment. And when young people are informed, they can shape their future. They can have healthy lives. They can have safer futures. And so on this day when we are celebrating World Sexual Health Day, it's important for us to empower our young people. Young people listening to me, it's important to be informed. It's your right to know. Knowing does not sexualize you. No. Knowing gives you power. It gives you information. It gives you education that you can make the right decision. And so I really want to encourage collaboration among stakeholders, be it CSOs, governments, institutions. There is need for collaboration. There is need for innovation, and there is need for continuous investment on youth sexual health education, without which our young people will suffer, without which they will not attain their safest level of sexual and reproductive health. It is important. It is not a taboo. It is their right to know. When they know, they will make the right decision. And so I really want to thank, Ibis Reproductive Health very much for bringing out this topic, because most of the time it's a no-go zone. It's a shameful thing to talk about. It is not. It is just that we are not facing the reality. And whether we like it or not, if we don't face the reality, we will face the negative consequences of not educating our young people. So I want to end here. I'll be happy to take any questions. And thank you very much. And over to you, Sezona.
It is not taboo, it is their right to know. Thank you so much for that, Anau. And as I hand over to Sister Judy to share insights on the impact of stigma in providing abortion care for young people, please just remember to use the Q&A feature to ask any questions you have for our speakers. Like I said, it is the speech bubble with the question mark in the middle labeled Q&A. If it is not in your immediate icons at the bottom of the screen, just click more and you should see it there. You can ask your questions using your name, or you can ask anonymous questions, but please do ask. We have a Q&A session at the end. Over to you, Sister Judy.
Good afternoon, everybody. Thank you ever so much for inviting me and to talk about the almost important topic, and the fact that we are actually going towards this World Sexuality Day is actually very important. So in my context, abortion stigma shows up in 3 levels. So it starts with institutional or structural, interpersonal, and also internalized or self-stigma by the youth themselves that come in the facility. And as Tepo was speaking, I was actually saying, telling myself that I must start by saying to Tepo that I'm 54, I'm very woke, and the young people love talking to me. So it's a matter of, we need to understand that generations are changing, a lot of things are changing, and we need to change with the times. You know, even when I'm in class, I actually tell my students, we are not living in that world anymore where we are saying you must have sex after being married, because that's not the way. People are cohabiting, so we need to move with the times and understand. And we also need experienced people like me to guide the young ones that are going to go into our shoes so that they can provide a better care and a holistic care to everybody. So when I was talking about the structural or institutional in my context within the medical field, there are a lot of issues. For example, we have a lot of gatekeeping in our facilities, and the gatekeeping could start with the fact that we still battling when it comes to abortion services with people that still have their values not actually aligned with what they are doing. And hence we always stress to healthcare providers to say, despite the fact that we have our own values, the department has got an obligation to provide these much needed services to the public or the youth that actually come to us. So it's very, very important that we actually need to address that. But during these times, I've actually found something quite disturbing, that we find that even before the youth comes into the gate of our facilities, we have securities by the gate who will actually be the gatekeepers and not let people come in. And I will at the end actually tell you what our plans as to when we picked up this, what we are intending to do, because it's a matter of doing a values clarification from the gate of these health facilities up until the service point where these youth are actually supposed to get the service. The second one, with the structural or institutional, obviously is the hidden services. We all know, we've tried for many years, we're still battling now, even just with the wording of saying, do we say termination of pregnancy or do we say abortion? And once again, it's a matter of comfort where it is not even clear. And at the moment, like I'm saying, we're moving with the times. We actually want the youth to find it more comfortable, even if it's online, so that they can find the correct language that will actually tell them about the proper service that they need, that is not hidden, so that they too shouldn't become uncomfortable seeking these services. Conscientious objection, we have to be real about it. It does exist. You don't always find people that are comfortable providing the service. It is not well supervised, because people can just, or healthcare providers can just come up and say, I will not provide this service. I'm a mother, I wouldn't even provide contraceptives to anybody that is 12 years old. We are working very hard to change the values of these healthcare providers to say that it has to happen. So conscientious objection is real, it's working, and people are actually enforcing it and getting away with it. That is why it plays a very crucial issue when it comes to stigma for the youth to access our services. And obviously, our facilities, most of our facilities were built in such a way that privacy was not enforced from the time the youth actually come in. So you find that there is a little booth, but then the person on the other side, whether it's a receptionist or whoever, or somebody at the help desk, will actually ask very loudly, "What are you here for?" Family planning, and obviously, or abortion, or the abortion sister. That is why the youth don't actually want to come. That is a problem. And with the structural issues is also the scheduling barriers. Our facilities are not designed to actually accommodate the youth. I've just come off the field now. I went to vaccinate communities in the road, and we just heard from parents that the majority of the children are in school. By the time they come out of school, it's 3 o'clock, and I would have been gone with the van away from the field for them to come. So these are all the structural things that actually play a big role, because they cannot access the service while they are in school. We do not particularly have services that are happening after hours to accommodate them. And we also don't have weekend services for them to actually come in there. So it's a matter of all these things that need to be fixed to can prevent these youth or the adolescents from being ostracized from our facilities. When it comes to interpersonal issues that actually play a big role with stigma as well, it's the judgmental language. So people don't know how to address the youth. They don't know how they can even be in their times to get them to understand what they want. And they're also not explaining to the youth, like one of the speakers had said, explain to the youth in their own language so that they can understand. And when it comes to things like contraception, and it's so important that language should be used that the youth can understand. And the biggest challenge that we are having now is that we, just last week, we were busy with a couple-year protection rate. We find that we have clinics that give plus minus 56,000 Depo-Proveras, which are the injections, to the youth. So they come, they seek an injectable, they go, but they actually stop taking the injectable because it comes with side effects. So did anybody explain to them? Did anybody tell them what to expect? Did anybody give them choices to say, this is what is going to happen, we can offer you this? So we actually trying to work on that, because those are actually the biggest barriers. And that is why we are failing, because when you look at our data of the under 19 youth that delivered in our maternity outpatients unit, it is actually frightening. So it would actually ask you that even if they had consensual sex, you cannot be having within a year's time more than 30,000 under 19s that are having that had babies, even 10-year-olds and 12-year-olds that actually delivered. So something is going wrong. We are either failing them, the choices are not being told to them, and once again, sexuality education is not done fully within the schools. And that's also another topic for another day, because just today we were having issues with the school governing bodies to get into the school for something that is as dangerous as diphtheria, which is a public health emergency. We could not go in and actually provide vaccination, yet we have a child that died in the school because of that. So that is a big problem. Unnecessary requirements as well, where the healthcare providers ask about the parents, and that also comes with the fact that healthcare providers never read the acts, they never read the guidelines and the regulations. They don't know what the Sexual Offences Act actually says about obtaining contraceptive. They don't know that the CTOP Act of 1992, of 1996, actually supersedes the Children's Act and the Sexual Offences Act, to say if a 12-year-old walks in and they seek an abortion, you don't ask questions, you don't ask them where is their parent or their guardian, if they are comfortable, and you've given them proper education and you've ensured that they are being supported, and you are sure that you've advised them to get somebody, and if they don't want to provide the service, that's a thing. But a lot of these youngsters are actually sent away from facilities and end up coming back to the facility when it is actually quite late. I'll just tell you a little story of a 14-year-old that came to our facility to seek an abortion, and she was over the 20-week mark, and she was told to actually go to the basic antenatal care clinic to go and book, and she didn't. She went to wherever she went, got whatever she got, she delivered that fetus, she buried it behind the house, and the dogs dug it up. And we got to find out about it when the police brought her in handcuffs at the facility. So these are the issues that we are having. And also, like I said, this coercive counseling is so important, that all methods of family planning are actually explained. We are actually also at a disadvantage because we have the contraceptive guidelines that came out in 2019, but we don't have all those methods in our facilities. We don't have the patch, we don't have the ring. We do obviously have the Mirena, but we don't explain properly how these actually work. And the side effects, once again, are our biggest challenge, where the young people do not want to use them because they are scared of all these things, because they lack knowledge. And obviously self-stigma is also a thing. We're still having issues with the youth not being able to come to the facilities because they are scared of being stigmatized, they are scared of being seen, even though we have in section 12 of the Constitution that, and even with the Bill of Rights, that clearly states it out, that we're not even supposed to assess them. They can access reproductive health services. The mother and child can access these services anywhere within our facilities without being asked any questions. But because we still have issues of jurisdiction, of people having to go elsewhere, and the youth being uncomfortable in accessing our services, that's our biggest challenge. So we have a mandate right now of the ideal clinic with quality assurance that requires each and every facility to have an adolescent youth-friendly service. But that is tough. I'm within a district that only has 3 at the moment. We're having healthcare providers who are not even trained, because I don't know if all of you know, within the nursing curriculum, even with the doctor's curriculum, you don't do family planning as a module. You don't do comprehensive abortion care as a module. All these things are done when people have completed their initial training. So we are having challenges that we would like to have adolescent youth-friendly services in all our facilities, but we cannot just launch when we don't have somebody that is not trained in reproductive health, that is not trained in acute and chronic diseases, and that is not sensitized to actually deal with the adolescent and the youth. Hence, we do not at the moment have, even though it's an ideal clinic requirement, we do not have these services as standalone services where the youth can actually service these. And at the moment, the majority of our facilities are focusing on acute and chronic diseases where the youth cannot access these services. If anybody accesses our services from the morning, as people queue up from 3 o'clock in the morning already outside our facilities, from the time the facility opens up until lunchtime, we are dealing with a bottleneck of acute and chronic diseases that need to be seen. No youth are going to want to come to a facilities when they must sit so long in a facilities. We are even struggling to get the emergency contraceptive out. Well, a lot of the youth, if they do have money, they'd rather go and buy it at a private pharmacy when we actually have it for free. Because if they come to our pharmacy, in our facilities, in some facilities, they are not just allowed just to go and get it. They first need to go to the reception area, open a folder, shine the benches all day in a facility waiting for that. So those are all the issues that we are actually having. And how does this impact the youth? So obviously we have a lot of delays. Like I said, we have that 14-year-old that came in and she was already 23 years old, 23 weeks of gestation with the pregnancy. Because they are scared, they wait until it's too late for them to come. Because they are scared, they do not come and access the contraceptive services at our facilities. Because they feel uncomfortable or they don't want to wait all day, they do not feel like coming. But and it also causes a lot of psychological harm to them. I mean, when we speak to them, we just had a youth event last week. They feel ashamed. They don't want to talk. They feel somebody's going to judge them when they talk about something as private as contraception, something as private as STI, and something as private as, you know, nowadays we need to they do this and we just get on with it. So we need to get in tune with being with the times, to serving everybody that comes in our facilities, taking appropriate history, being sensitized and being able to deal with people who are gender non-conforming, like the LGBTQIA plus people, and also the sex workers who don't find it comfortable coming to our facilities. And all these are actually rights violations. So education is supposed to be within communities, because it's our communities, families as well, that cause these challenges, because they are not comfortable speaking to their own children, and the youth and the adolescents are also not comfortable speaking to their parents. So that is also a challenge. And we are actually trying to do that within our community hubs, to say we need to let the community also understand that, yes, we can talk about abstinence, but unfortunately, we can do all the talking we want. I just went to a school yesterday in Mitchell's Plain where the teachers were telling me that when it's break time, they don't sit in the staff room because the boys and girls do orgies and they have sex in the toilet. We have one boy that has 3 girls in grade 8 pregnant in one class yesterday. I went home, I didn't even know whether I was coming or going. But this is the reality of things. Things are happening, sex does happen, and unfortunately we have to move with the times and enforce these. And like one of the speakers had said, we have these policies. I'm not sure whether healthcare providers don't read the guidelines or whatever, but we need to enforce them and make sure that everybody knows about them, and we also need to enforce them as well, and also make sure that the signages are proper, and once again work in collaboration with other stakeholders. SAPS is also one of our biggest challenges because they have jurisdictions. I mean, if I must speak about gender-based violence as well, we have somebody being raped in one area, they cannot access abortion in a different area because the rape happened in a certain area. So we need to work with all those people. We need to work with social development as well, because like I said yesterday, I was at the school in Mitchell's Plain, where how important it is to work with social developments to make sure that we do proper assessments of these families, because of the socio-economic issues, because of poverty, drug abuse, unemployment, a whole lot of things. I just came off the road now. A lot of youngsters are wandering around the streets, and those are all those things that we actually as society need to deal with, and it's much bigger than us just offering services at our facilities. We need to go out there and make it a community-orientated program and make sure that all the youth are seen and heard, and they are also part of what is actually happening. Because if they are also involved, it'll be better. We are struggling though to also get them, because even if we want groundbreakers to actually become youth, some of the youth, as much as they say we should not speak for them, we should not do things without them, they don't actually want to become part of committees or be groundbreakers or be there and be peers to their own peers so that the word can come out freely. So we are struggling with that, and I think it's very, very important that we need to get the youth that are outspoken, that are brave, that could actually be an encouragement and go out there and make sure that they encourage the others to be part of this health system and be there around tables when decisions are made. I personally stand here and say, I struggle to get them around the table where they need to be, where decisions are supposed to be made for them. I really, really struggle. So once again, it's so important that when we want to tackle stigma, it should be done at every level. Like I said, I started with institutional and interpersonal, and as well as the structural. Very, very important. So all those aspects must be sorted out so that we can make sure that our youth is there and can be taken care of. But for now, I speak with a heavy heart, because every day of my life, I meet up with youth that find themselves in compromising situations. And we give education. We are open out there. We are trying by all means. We involve the newspapers. So I'm hoping from here on, word can go out that we also need to work with them. We also need to make them aware, because from where I'm standing, we are pushing. We are pushing for services to go out there for them. We even push for them. At the moment, we're busy with the department to say, let's make the BeWise apps and the Grit apps to be 0 rated, so that the youth don't have to come to the clinic. They can chat with the providers online and then come and access the services at our facilities. So we need to move that way. And I'm proud to say for now, we have youth that are saying, Sis Judy, we'll rather than go on TikTok, because it seems like TikTok seems to be working. So they are brave enough to say, we'll go on TikTok and speak about this, and hopefully we will get somewhere. But for now, all I'm saying, whoever that has lost hope with the department, there are some of us that are trying our best. And every day of my life, I tell myself, even if I just save one child, I will be there to offer the service and support. I thank you.
Thank you so much, Sister Judy, for highlighting the importance of information in enabling young people to make informed decisions. At the risk of sounding like a broken record, please remember to make use of the Q&A feature to submit questions for our speakers. Moving on to our next speaker, we have Mmoho from Code to discuss countering misinformation to young people and the effect that this can have on SRHR services.
Thank you so much, Sesona. Good afternoon, everyone. So I am Mmoho. I'm the Head of Research and Programs at the Campaign on Digital Ethics. So what we are is a civil society organization that actually focuses on advocating for digital rights and ethics. And how we do this is actually by ensuring that they take accountability, we counter disinformation and misinformation as much as possible. And then we also try and empower, individuals or organizations themselves to really understand what their digital rights and ethics are and how they can engage effectively with others online. And so what we do is we want to base this work on democratic principles. And so it's very important for us to engage in such conversations like today's conversation, because again, it's very important that young people understand what their rights are, young people understand what is happening online and know where to go for any sort of information that they might need. But also importantly, so that policymakers can actually engage in these conversations with us as civil society organizations and members of the public around where the potential gaps are. Next slide, please. So maybe to start off with a few statistics regarding use by both young men and women online in particular. So the International Telecommunications Union found that globally 70% of men are actually using the internet in comparison to 65% of women. And this is quite important because it highlights the digital gender divide in particular globally. So from an African perspective, what we found was that the figure stands at 43% for men and 31% for women who use the internet. So whilst the digital gender divide is decreasing, the progress is obviously quite slow, and it depends on where a country is situated, how people have access to the internet, and what they do with the internet as well. So for the youth in particular, this is now for 15 to 24-year-olds. We found that they were 1.9 times more likely to use the internet than other users. So young people are engaging online, they're making use of access to information online. And so it's very important that the information that is online is information that is accurate, that is verified, so that they do not spread misinformation. So both women and girls are using the internet as a source for health-related information. However, like I've said previously, some of the information can be unverified and there are inadequate safeguards against mis and disinformation. And we'll speak about that a little bit later. So what research studies have also found was that during times of uncertainty, for example, the COVID-19 pandemic, resources were being shifted globally from maternal health care, for example, to other services. And what that meant was that women in the healthcare sector were obviously more vulnerable to job losses due to what is known as overrepresentation in those sectors. So quite sadly, mis and disinformation are actually gaining traction online on key topics that are related to legislative reform that may include information on sexual and reproductive health rights. Next slide, please. So just to give everyone in the room an overview of the types of false information that have been identified. The first one is false information, right? So false information actually refers to content. So any posts, articles, voice notes, videos, images that contain any kind of lie, falsehood, or inaccurate information. Then you have what is known as disinformation. So disinformation is content that is actually intentionally created and disseminated with the purpose of deceiving someone or group of people. And how we say to people, you should remember it is relates to deception or deceiving. And then there's also lastly what is known as misinformation. So misinformation is when people share wrong information or misleading information without meaning to deceive others. So it's that WhatsApp voice note that you receive that goes quite viral in the group chat that urges you to act immediately You share it because you believe in it, but you haven't verified it and you don't mean to deceive others or harm others. So what are the harmful trends that we're seeing online? Next slides, next 2 slides, please. So I just wanted to show some photographs that we actually captured while we were preparing for this presentation today. So the one on the left says, the safest way to abort a 7 months pregnancy at home by yourself is making use of malt, milk, and H2O water. And you mix this into a drink and you should thank the person later. Obviously, we know that this is a form of disinformation because one, it is not verified that that will assist someone in accessing an abortion, but also it might have detrimental impacts that are not verified by healthcare practitioners. And just to note that this was a screenshot that I took from a TikTok video that is actually quite available. And there were people who had actually engaged with this particular video, had liked it, had asked questions. And that is why disinformation is very much misleading, very much dangerous, because people start believing that this is actual verified information, even though it is not true. They don't know who this person is. This person may or may not be a healthcare practitioner. I think they're not. And so they're spreading this information. The image to your right-hand side is actually a screenshot during 2024 where people were engaging on the Now Bella Act. And so you would have seen that with the Bella Act, at the time when it was still a bill, a lot of people were engaging and there was a lot of fear and misinformation being disseminated online around what the Bella Bill Now Act actually purports to do and what it stands for. So it says, if I'm so wrong about the abortion part, tell me what does the management of learner pregnancy mean? I think they meant that what the learner pregnancy terminology or section means in the actual bill at the time. And so they were circling this, sharing this. It was liked by 165 people and 20 people had commented. I went through the comments and luckily some people were calling this out as misinformation. But the person was basically alleging that the Department of Basic Education and government more broadly was actually trying to get or pushing for young people to get abortions. As we know, the CTOP already exists and it does provide provision for access to safe abortions. But again, people don't have access to this information. And so people rely on these platforms because they think that the people who are sharing this information know what they're speaking about. Next slide, please. So also on the actual, so on the actual Bella bill at the time, I also took a couple of more screenshots. Again, these were comments that were being made by people on different posts. And they were saying that the government will take your child for an abortion without your knowledge. They were saying things like, so one can have unsafe sex and murder the fetus. This government is ungodly and are satanic. And then it also means that you no longer have any rights as a parent. If they think your child should have an abortion at 12, they'll take her without you knowing and providing consent if your daughter shares a unisex bathroom. And so you will see that with a lot of misinformation, there are lots of spelling mistakes. There's a sense of urgency that is created for people to act. It also then is done in such a way where it creates fear in individuals. Again, this is fear that is based on the fact that people don't always have access to this information. So they see these viral videos or posts or voice notes on WhatsApp, and they engage based on that. Next slide, please. So on this, also an interesting development that we are seeing online is actually around AI-generated content or deepfake videos, as they're known. And so these are videos that you can create using someone's image, using someone's voice as well, depending on the kind of tool that you use. And those are being used to spread false information and impersonate public figures in healthcare. We actually saw it quite recently with Prof. Salim Abdul Karim, where they had created a deep fake of him speaking about the COVID-19 vaccine and basically saying that the COVID-19 vaccine was terrible and that it has detrimental impacts, health impacts for individuals who had taken it and encouraging people not to take the vaccine. And as we know, he had not actually engaged in that particular interview. What they had done is that they had taken a previous video of him speaking and they'd utilized a voice tool that made it sound like it was him. And then they had disseminated this on social media platforms. Again, very dangerous content that is being created and that really creates rollbacks in progress that is being made for healthcare in general, but more so on things like sexual reproductive health rights as well. And so these kinds of videos can actually erode public trust because people see them and they believe it. I will be quite honest in saying that AI tools are getting more and more sophisticated. So for a lot of people, it's quite difficult for you to know whether a video or an image is actually AI generated or whether it's quite truthful. And so it's important in the kind of work that we do and in the conversations that we have, that we teach people, especially young people, to be able to pick up on what is AI generated content, how to look out for it. And I'll speak to that a little bit later in my presentation. And so what we do as an organization is that we offer digital literacy training for various groups and individuals to raise awareness on these kinds of matters. So I think that it would be very important for us to also talk about something that we are seeing gain a lot of traction globally, and that is technology-facilitated gender-based violence. And the UN Women has defined it as any act that is committed, assisted, aggravated, or amplified by the use of ICT or other digital tools that results in or is likely to result in physical, sexual, psychological, social, political, or economic harm or other infringements of rights and freedoms. Next slide, please. The reason why I'm noting this is because it's very important for us to note that technology-facilitated gender-based violence, or TFGBV as we know it, has actually been found to also impact healthcare practitioners across the globe. We saw it particularly during the COVID-19 pandemic, but we are also seeing it with the misogyny and the development of the incel culture, where people are going and attacking healthcare practitioners, particularly those that do work around sexual and reproductive health rights, because we have seen that countries are rolling back, unfortunately, on these important human rights. And there is that movement online that is currently happening. And just to note that with technology-facilitated gender-based violence, or TFGBV, it happens online mostly, but it can spread to the offline. And in actual fact, there have been studies that found that healthcare practitioners had actually stopped engaging, and they had to make the decision around whether they wanted to engage and develop in their own careers because they were either being harassed or doxxed. So doxxed is when you have people sharing, for example, your physical address or your telephone number on a very public platform. It's illegal, but people do it nonetheless. And then you suddenly have people contacting you, harassing you because of, for example, a presentation that you would have made or an article that you would have written. And it's important for us to note that these developments are happening, and it's important for our governments to really ensure that they protect healthcare practitioners, but also to note that this is not only just happening to healthcare practitioners, but it's also happening to youth themselves. We found that, again, youth are also being impacted because people can create the deepfakes. People can dox them or harass them or cyber stalk them online because of their viewpoints around sexual and reproductive health rights. And we've seen that again, there's this impersonation in particular of individuals who are actually in positions of power. So just to note on this slide that there's something called misogyny, the manosphere, and TFGBV. And what we've been saying to people as an organization is, so the manosphere, as it's termed, is actually meant to address men's struggles, but it's done in such a way where it promotes harmful content or narratives which can lead to violence against women and children, because women are meant to be viewed in a particular way, which goes against how we know that women should be viewed, for example. And you see this in very popular podcasts across the globe, where conversations are being had about women in particular, and young girls as well. And then these views of women and girls obviously pose real threats to women who access and provide SRHR related healthcare. Again, just tying it in with, for example, the healthcare practitioners, doctors, nurses, community healthcare workers who have to do this work and are providing access to that information. And lastly, to say on this point that AI content and anonymous accounts can actually be used to harass, impersonate young women and girls themselves. And I think it's important for us to start doing that research around how TFGBV actually impacts youth, particularly looking at it from a focus of sexual and reproductive health rights, not only in South Africa, but across the African continent. Next slide, please. So how do you navigate misinformation online? So what we say is that you need to verify before you amplify. So what does this look like? So now you have received a voice note, you've received a deep fake, or you've received some kind of photograph that has some level of misinformation, but at that point, you're not sure whether it's misinformation or not. The first thing that you should be doing is looking at whether the information that is being shared is actually factual. So you would look for evidence which actually supports that particular fact that is being put out there. For example, one of the things that we saw again on the TikTok platform was now there's this huge movement of people that are actually excuse me, that are actually selling so-called womb cleansing toxins or elixirs, and they're selling them to women who have accessed abortions. And they say to women, this will help you, this will ensure that, you know, going forward, your fertility is good, etc. And again, spreading misinformation, but it's also done in such a way where people are able to sell their products. And unfortunately, people can still sell these products without being held accountable until they're reported, because one, most people don't know that you can't just sell something that is not verified. Two, people don't understand that it could actually harm you and do more harm than good. You could land up in hospital, for example, or it could create complications. But also, lastly, to note that it actually creates misinformation, because when you access sexual reproductive health at a clinic, at a hospital, obviously the healthcare practitioners provide you with adequate access to information around what to do going forward, what symptoms you need to look out for. But again, we're seeing these developments in real time online. So one thing that you must do is look at reliable evidence that usually includes statistics from reputable organizations. So for example, you've got your News 24, which has a fact-checking desk, you've got your Africa Check, and you've got your Media Monitoring Africa that do the work where they source out any mis or disinformation, and they put it up on their websites and they're on their WhatsApp lines, and they provide access to the public around what kind of misinformation is out there. So the second thing is to look at who is the source. So who's the person who actually first shared this information? So is it an individual, an organization, or a news outlet? The most important thing is you need to check their reputation and past accuracy. So if it's a post by anonymous account 21345, for example, and this person has never posted, this person seems to be posting things that are inaccurate or things that look a little bit suspect. It's best not to trust that source, definitely. It's best to go back, check the internet, Google, read the books, go to your local healthcare facility, ask doctors as well around, is the information that is being shared actually factual? And then thirdly, is it trustworthy? So if news comes from a reputable news outlet, we are most likely to trust it as being accurate because there are adequate checks and balances because of the ethical nature and reputation, sorry, that those news outlets need to have. And so we know that any information that is disseminated, particularly around SRHR, should be information that is accurate and fact-checked. And then fourthly, to ask, are there any biases? And this is an important one, right? We need to figure out the possible bias of the source and the intent behind the information. So for example, now, what we're seeing is that people are being chased away from clinics when they try and actually access healthcare. So the first thing that we need to ask ourselves when we see these videos and people are then saying, oh, we need to go to the clinic and actually do something about this and stop people from accessing healthcare, we need to figure out what biases are at play, right? And we need to figure out the intent behind the information that we're receiving. So is it meant to inform you of something that is happening? Is it meant to persuade you? Most of the information is meant to persuade you to do something. So we saw it with the July 2021 protest as well, that people were actually being persuaded to do something, and that's why they went out and started protesting. Is it meant to then incite some kind of harm or violence? So every person on the earth has some kind of bias. So it's important for you to pause and think about what potential biases are at play, both by the person who shared this content or information and you as a receiver of this content or information. Then lastly, does the content actually stir strong emotions, right? So dis or misinformation actually aims to elicit very strong emotions from individuals and engagement, because again, there are people that are making a lot of money from the fact that you're engaging. There's something called rage baiting, where people become angry, they share this information or the viral videos or the WhatsApps, and then people make more and more money because we are engaging. So it's very important to figure out if it's making you angry, if it's making you sad. So before you share the content with others, you need to ask yourself these 5 questions. So the next part of my presentation will talk about communication. So how do you communicate with care? So when you do receive this content or information, you need to stay calm and engage quite respectfully, because again, it can incite, it can inform or persuade people to do certain things. You need to then include evidence for that person that you're engaging with, right? If you know, for example, what the CTOP says, it's very important when you're engaging with someone who is then spreading this misinformation around the CTOP, to let them know what the CTOP says, where they can find access to this information, and what the particular act speaks about. And also to engage with them around what are the rights of youth, in particular when it comes to sexual and reproductive rights. And then ask the questions. So asking them, why are they sharing this content? Where did they get it from? What do they think about it is quite important. And it's very important to use non-confrontational language, because these conversations can become heated, as we know. And then last but not least, at some point, if the individual or groups of people do not understand, it would be important for you to disengage if necessary. So I'm going to move on to the next part around countering misinformation. So what do we need to do going forward? Because we've seen that there are big problems. And just to note before I jump into this section, that technology also provides us with good avenues to share access to information on sexual reproductive health rights. So not everything about technology is bad. I need to reiterate that. So for example, lots of movements are sharing information around accessing SRHR on WhatsApp platforms, for example, that's easily accessible. That's another platform that young people are using. Healthcare professionals are also engaging on TikTok platforms, on Facebook as well, just to provide access to that information. So it's important for us to not see it from a one-sided viewpoint. So with that, so how do you counter misinformation? The first thing is that you need to utilize fact-checking tools, which I'll speak to a little bit later on. It's then important for us to develop community-oriented health campaigns on SRHR and what these look like. And I'm very glad that Sister Judiak was here, and Dr. Eno and Tsepo, who started speaking about the fact that we need to be engaging and educating others around their sexual reproductive health rights. We need to do that in a language that is understandable to the communities that we serve and that we speak to. So the language that you would use for an adult might be different from the language that you use for youth, because again, there are developments that are happening in real time for youth, and it's important for us to engage with youth around that. The third one is we need to use technology and social media, pardon me, as a means to capacitate the youth and provide avenues for engagement. It's very important for the Department of Health and others to start engaging quite positively with social media platforms, spreading information around what youth rights is when they're trying to access sexual reproductive health rights. Because again, we're seeing developments, for example, around potential misinformation that concerns the use of contraceptives, and we're seeing that in real time. And that means that young women and girls now are moving away from using contraceptives due to the misinformation that is out there. And that has an impact on our healthcare system. And then fourthly, to address online bullying and harassment of healthcare practitioners. Again, it's very important as we see more developments in technology. We've also observed that unfortunately, healthcare practitioners can be doxxed, can be cyberbullied, can be stalked online when they're trying to provide access to information for young people. So it's important for us to call this out for what it is, which is technology facilitated gender-based violence in some instances, or doxing, or cyberbullying, or harassment. We need to report these accounts, but also we have a duty to not be the people who actually bully people online and harass people online, who are trying to ensure that our healthcare system is as adequate as possible for young people. Then lastly, we need to develop collaborative digital literacy campaigns focused on SRHR. So it's important for us to engage with Ibis Reproductive Health and other stakeholders around SRHR on very important days like this, but also to continue to do the work across the year. Next slide, please. So importantly, in terms of providing access to information, the World Health Organization has actually now developed a digital repository and tool for family planning. It's available on their website. And again, this is a tool that can be utilized to provide access to information. Again, it can be trusted because it's from the World Health Organization, which is the biggest health organization across the globe. So we know that any information that they put out is verified, it's accurate, it's based on statistics and research. So in closing, I just want to quickly speak about something that is not captured on these slides, but it's quite important to speak about, and that is mental health. When we've had these conversations about sexual reproductive health rights, we know that young people are being faced with quite a lot of information, and sometimes it can become quite a lot. Young people are living online. They're using the internet to access information around healthcare and other things. And so for us, we always say to people, firstly, unplug. So take the time out from social media. It's not healthy for any of us, including us as adults, to constantly be plugged in, to constantly be utilizing our cell phones and scrolling. It's very important for you to take a break. One, it's good for your brain. Two, it helps you think outside of the box. Thirdly, what most people don't realize is that when you're constantly engaging on social media or social platforms, it gives your brain the dopamine hit. So you become addicted to social media. And that's why sometimes you will find people, even during supper time, even during class time, they're on their cell phones, they're scrolling, they're not paying attention. And it might be that some people even now on their cell phones scrolling again. And it's quite important for us to be present in the moment and to just step away from our tools. It's important for schools to do the work with young people. Previous speakers have noted the fact that the youth have a voice and we need to engage them on these things. Sorry, I know that I'm fast running out of time, but to say that schools must do the work in terms of the curriculum, in terms of engaging with young people around technological developments, really letting them know what is happening globally. So what is a deep fake? Young people most likely already know what is AI, what is a deep fake. Most young people access tools. My young niece has created an AI generated a video of me and I didn't need to teach her how. So, and she's a teenager. And so young people know how to access this. The best thing that we can do for them is ensure that they access this information, access these tools, and they do that in a way that is conducive to them and conducive to their communities. And then lastly, just to note that if all of us can tonight do our homework, right? So go through your social media feeds. What are you seeing? Start picking up the trends. What are you seeing more of? Because again, how social media works or how these platforms work is you watch one video and then you start seeing more and more content that is related to that. And it's important for us to get out of our echo chambers and start engaging with different people on different topics. Because again, if you are in a WhatsApp group, if you are in a space that provides misinformation, you might not even pick up on it because you're locked in that echo chamber. Then lastly, on the screen, you'll see a list of resources. So Code, you can access us on www.codesa.org. We have newsletters that speak about different issues, including some that I've already spoken about, and we've created actually health-related videos that are sharp 2 minutes long that speak about different issues that can be shared. There's also Africa Check, Media Monitoring Africa, that do the work around helping you figure out if something is mis or disinformation. You can use Which Face is Real. This is a nice tool that you can use that actually helps you practice pick up on AI-generated images in particular. There's also www.snopes.com that also helps you with AI and access to information. And then there's the classic Google reverse search, reverse image search. And with that, I just wanted to thank you.
Thanks so much for that, Motlatsi. And as we move on swiftly to our last speaker for the day, Khuliso Managa, to inform us about youth rights to accessing SRH services. Over to you, Khuliso.
Okay, thanks. Hi, everybody. I'm assuming, okay, my presentation is loading. I think everybody who has gone before me has really done a very good job and have had a very interesting conversation in relation to kind of youth access and the challenges that we're having. And I've really highlighted some of the issues that I wish to kind of expand on, which predominantly kind of sit in youth really having a challenge with kind of first and foremost understanding the parameters of their rights, and then after that being able to really access and exercise those rights. And we're finding that, particularly in the youth space, because there's so much fear, misinformation, lack of access to information, and so much confusion going on in this space, it is very common for minors to get lost in all of the noise and in all of the confusing languages and confusing concepts that they're not really always ready to kind of delve into. And most really give up really quickly or are more comfortable with maybe having more personal referrals from each other and information sharing rather than trying to kind of expand into environments or networks that provide this information. Just because of existing stigma and concerns with, of course, they themselves being asked too many questions or being placed in uncomfortable positions, and a lot of fear that youth themselves have with kind of talking to adults, and particularly adults that they themselves are not comfortable with. And alongside kind of that internalized stigma that Judy mentioned, there's also then the external issues that they deal with where they're being reinforced with these fears and where these fears come from, where they've interacted with perhaps kind of teachers, healthcare providers, or a social system that kind of looks negatively at the idea of them asking questions or having these conversations or engaging on these topics as have been highlighted before. And so it's really kind of increasing and forever important that a lot of effort is put into doing work like this and doing work that IBIS does, in which really trying to get information to where youth are. And this is why we have conversations about CSE being such an important tool for youth, because without this information and without appropriate information, they're vulnerable to so many other things that really lead them down a very horrible rabbit hole that is very difficult to recover from. In the example that Judy made, South Africans and like the South African population has really been struggling with high abandonment rate, fetal deaths, and really high teenage pregnancy rates that go on for much longer into the pregnancy than they really need to, because really grounded in this discomfort that youth have when it comes to accessing information and having information. And there's also in itself, when it comes to youth, because as a society we're very conservative, the general norm is abstinence. Conversations about when age-wise sex is appropriate or when these tools need to be shared with minors is really something that we are still having currently as a society, which has left a lot of youth in the dark and have left a lot of minors in the dark to really fend for themselves. And in that space, never mind the existing legislation and laws on kind of consent being as well very murky and being very much so something that not all adults have kind of a general knowledge on and can off the bat, other than saying just don't do it, can really provide a lot of general guidance on. So we also find that kind of because access to information to the general public and other adults on what minor rights are is very scant and very little. They themselves are very left behind in terms of providing this information to youth, and they themselves are not able to then aid minors in kind of guiding them through the stages of when they're moving through this SRHR environment. And so for kind of the conversation that we're having today, I just wanted to kind of highlight some areas of kind of typical confusion and areas that are still could benefit a lot more with a lot more highlighting and with a lot more kind of focus on in the general space when it comes to information that is given to youth and is related to youth. We really wanted to focus on kind of the idea of consent to medical treatments, age-wise, access to contraceptives, confidentiality, and kind of the fringe areas of gender non-conforming minors, queer minors, minors who have mental disabilities or mental illnesses, and really how to navigate spaces between kind of teachers and healthcare providers in terms of the general perceptions that they have when it comes to teenage pregnancies. So when it comes to consent for medical treatments, we really, at this point, there's a distinction between minors who are above the age of 12 and generally underneath the age of 12. SUTOPA itself, when it comes to terminations, does not put an age restriction on access to abortions. And so that legislation by itself has done really good work in making it accessible to youths. And so on that ground, minors can access abortion without having to face any questions or to require parental consent or adult intervention or adult support. Usually within this realm, it does garner a lot of concern from parents because there is no age restriction, and they worry. A lot of adults are, like it was mentioned in a lot of the misinformation, where they're worried about children being kind of pushed into these spaces. But that legislation was really mainly designed in that way to ensure that children really have autonomy when it comes to termination, and that termination is a lot more accessible. Especially considering how youths are really prone to delaying how long it takes for them to kind of first and foremost confirm a pregnancy, and then after that making a decision about their pregnancy and where they'd like to take it from there. Having kind of termination be accessible from the get-go is a very good fundamental step. Alongside kind of termination aside, generally minors over the age of 12 can independently consent to medical treatment. They can have privacy, so that usually entails if they are going for STI screenings, seeking kind of contraceptive information. There's a specific section in the Children's Act that specifically provides also that children over the age of 12 can seek, particularly contraceptives. They can seek both medical and surgical, or more the Depo-Provera kind of treatments that whichever version they'd like from the age of 12 without the need of taking a parent with or taking an adult with. And also within these confines, then they also have the right to confidentiality, which is implied when it comes to accessing healthcare services. The only distinction that's really made when it comes to access to healthcare is usually when it comes to surgeries. And that usually entails where minors are getting some kind of surgical procedure, in which case, in that context, if they are older than the age of 12, then a parent or guardian assistance is provided. So what's really important to highlight in these contexts when we have these conversations is often that the current legislation is very specific in that it provides that not only are children over the age of 12 able to make their own decisions, but in addition to that, they're not required to go through a maturity check of kind of healthcare providers or teachers or SAPs really asking them particular questions to gauge whether they are mature enough or whether or not they understood, they have engaged or asked their parents or have had conversations with family members. None of those conditions exist really. So for as long as a child can understand the benefit and the risk, which they naturally do by asking and requesting certain medication, and which is usually part of the process of a healthcare provider providing access to medication, where they usually have to describe kind of side effects and have to describe the conditions of specific medication. Within that realm, children should be operating, at least on paper, without restrictions. But as really Judy mentioned in her conversation, that's not often naturally reflected in practice. And this is something that's a little bit more comfortable to access for minors who might be going into the private sector more than in the public health sector, where it's a lot less private and there are a lot less potential for them to be construed as not having all of the rights that they are entitled to. Another area that we really wanted to canvass was kind of consent laws, which, I mean, we have the Sexual Offences Act, which really speaks to kind of sexual consent around minors. And highlights in this conversation, we constantly kind of endorse increasing access to information about sexual activity between minors and sexual activity between those over 18 and minors, and the technicalities involved, purely because usually there is a lot of triggering when it comes to officials and the idea of minors having sex or being pregnant, or these conversations that maybe are alarming, that descriptions of boyfriends, and then there's an overreaction that leads to minors themselves being reluctant to have conversations about sex and their own kind of parameters of how they're operating sexually. And so we always encourage kind of conversations about sexual consent laws, and where and when in the age gap minors kind of fall into, and when the parameters become concerning and for something that an adult should be concerned about. And this is kind of where it is into the area of where minors then get concerned about being reported often. And it's a really fine line, considering that South Africa has very high GBV statistics and we have very high rape statistics, where at the same time there's concern in trying to protect minors, but balancing that with their reproductive rights is a very big challenge that we still have as a country, and that we still need to grapple with. And often, and in the more recent years, there's been a very strong pushes towards kind of extending restrictions and protections that have been infringing on minors' reproductive health rights and rights that they have existing about their autonomy. And so that's why we encourage kind of continuing consistent education that kind of coincides with GBV conversations, that sex is still a healthy practice and can be conducted in a safe and mature manner, and doesn't need to be conflated with GBV as often as it is in public language. And so the next topic that we're going to usually face is in the arena where we've noted there have been kind of increasing concerns, or concerns from parents who might have children who have mental incapacities and might have children who have disabilities. And in that arena, the question of how consent works, consent being to contraceptives particularly, consent to medical treatments, consent to sexual activity as well, the kind of rules and regulations that apply in that area for children who have disabilities, have mental incapacities and mental illnesses, then kind of become a conversation that is not really had often, but in the area where we're really growing and really starting to understand mental illnesses and mental wellness and mental health. It's a growing conversation that we should be having, and it's growing issues that we should be able to disseminate information on. So legally, we have kind of a space in the law where every child over the age is automatically presumed to have the capacity to consent to contraceptives without parental consent or a maturity assessment. So that would include children who have disabilities, and children who have mental capacity issues, and children who have been identified as having potentially like mental illnesses, like for instance, there's always kind of stigma associated with concepts like depression or anxiety, in that it affects their mental decision-making capacity. And so the law has been very strict in trying to remove the association between an inability to make a decision and having separate mental health challenges. And so in the context of the law, restrictions really can only be applied once a very formal process has been followed, which involves a mental health assessment where medical practitioners, several medical practitioners at least, are involved, and in the absence of that, a court is involved to officially declare a person and a minor as unable to make a decision by themselves. And without following that very formal assessment and very formal process, a child's right from the age of 12 cannot simply just be removed to give consent, even though there might be concerns about their mental health state. That the two need to often not be conflated. And so it's often in this conversation that we kind of reinforce that, mental illness alone is not, and disability or incapacity is not a reason to take away a child's consent, even though there are great concerns. In these contexts for healthcare providers, teachers, and guardians, the approach that's endorsed is to at best assist a child in making these decisions or in navigating this space, and in ensuring that they have access to information and that they are processing that information in a version which works for them, and to take it from there. And opposition of the other approach that's taken, which is usually controlling and which usually entails abstinence and usually entails, in very worse situations, perhaps for minors with disabilities or mental incapacities, sterilization, forced sterilizations. And so in this arena, we have been really trying to highlight the idea of independent decision making, and also what supporting a decision in this context looks like, which really, like I said, involves making sure that the communication use is accessible in a language that they understand, simple words. It's really like other speakers I've spoken to, is really at the level in which that child is comfortable speaking in. It's not too paternalistic, and it's not in a way that's looking down at minors. That children are given enough time to think and ask questions, and then are given an environment where they can kind of think about their options and go back and come back. And that, their choices and autonomy is often respected. And so in a lot of programs and in the public health space, this can become a challenge when minors are navigating these spaces independently, and where there's not really enough resources to give them adequate space to kind of appropriately process these things. But this is where kind of support NGOs and alternative resources would really come in handy, and come in use to kind of create and bridge the gap between the experiences of minors in healthcare spaces or with teachers or with the public space, and kind of create a good middle ground where at least an alternative option is available. Another area we wanted to highlight was kind of LGBTQIA minors and gender affirming healthcare. There's been, of course, a lot of advocacy that has been done recently when it comes to increasing access, not only for minors, but for minors who are on the spectrum, and for minors who are queer, and in terms of them not only accessing healthcare services as every other person is able to in South Africa, but also accessing services that are gender affirming to them, should they be on the gender binary. And so in terms of these, we go back to what's been set out in the Children's Act, in which children over the age of 12 can consent to their own medical treatment, which of course includes gender affirming services like psychological support if they wish, and hormone treatment or puberty blockers should that be what they're interested in doing. Later on, should they be in, not necessarily later on, but should they be interested in gender affirming surgeries, the Act does allow children older than 12 to consent with assistance from their parents or their guardians, with a note here in the Act specifically really saying that guardians and parents can't refuse to provide assistance strictly on religious grounds or on other beliefs that aren't rooted in a genuine medical concern. in the absence of a parent or guardian kind of assisting, alternative adults or the state can intervene, which is obviously a high burden, but still the option is at least there for minors older than 12 to seek these gender affirming surgeries. And the confidentiality of their process in following this space is, of course, protected under alternative sections. And so there's been a rise in a lot of anti-rights communities spreading a lot of misinformation and fear and spreading a lot of stigma when it comes to minors accessing gender-affirming care, with concerns that they do not have the appropriate mental state to be making decisions about their bodies or to be making decisions of a permanent nature where they are. And this is where then the law has kind of put in place and has taken the time to really enforce the position that, and this is based on kind of research and work that's been done by medical professionals that supports the idea that minors are able to make decisions and should be able to make decisions about their body and their futures without intervention or without parental permission. And in these contexts, at the very minimum, only assistance is required, and assistance in the essence of we just need parents there to provide a supporting environment. And we've already discussed kind of termination rights, so I'm not gonna go through that again. The other two areas that I wanted to highlight was school reporting obligations and healthcare reporting obligations. And in these contexts, it's usually relating to sexual offenses. And pregnancy. So in the schooling space and in the healthcare space in the last few years, when it comes to the Department of Education and with kind of public push, there's been a lot of pushes towards since there have been concerning teenage pregnancy rights, teenage pregnancy rates, there have been pushes to instill, and also alongside our GBV concerns, there have been pushes, like I said, towards more action and more processes that are geared towards catching potential sexual offenses and catching violence and stopping violence against minors. And some of the areas in which violence against minors and sexual offenses are conflated in is in the issue of teenage pregnancy. So in some kind of state positions, there is some pushes towards creating kind of obligations for pregnancies in general to be reported to SABS, because there's a conflation of the idea that a minor cannot just be pregnant without it being rape, or it cannot just be a pregnancy without an assault being associated, and a contravention existing in there. And in these contexts, because the two issues are really conflated, we are seeing kind of a rise in infringement of learners' rights, and again instilling those stigmas and fears around teenage pregnancies that make children kind of fearful and wary of approaching adults or of disclosing their pregnancy. And so in school environments, we already know that there needs to be accommodation for pregnant learners, but we're finding more and more there's a need to have conversations with healthcare providers in the wake of these GBV conversations, that reporting a pregnant learner is not an obligatory overarching general requirement, and reporting is only required in the context where there is suspicion of a sexual offense and there's suspicion of a sexual assault, and only in that context is reporting mandatory. And so it is in that sense that we kind of encouraging this conversation and within the lines of pregnant learners do not have to be policed, and approach to pregnant learners should be supportive and should be within the realm of providing them access to their information and their options, and not in a nature of trying to prosecute or to assess what the big problem might be behind a pregnancy, which causes a lot of fear mongering in schools and in spaces where learners are supposed to feel comfortable with providing disclosure. And so really when it comes to statutory reporting, it really only applies in the context of concerns over the incidence of rapes and concerns over statutory rape where it's between concerning age group, and that's something that would happen during a health assessment. And so between both healthcare workers and teachers, there is no general obligation for reporting. It needs to be a very case-by-case evaluation. And a NUED's conversation needs to continue on these topics in those spaces to ensure that we protect kind of access and make sure that we are not moving the work that's been done on accessing and reaching minors backwards by trying to also protect them from another associated issue. Okay, and that is pretty much all I wanted to canvass and discuss. I think it's been a really good conversation that we've had so far. So I'm gonna hand over back to Ibis, who I definitely think the conversation that we've had here has been a really great initiative in terms of dealing with celebrating this day. So thanks, everyone.
Thanks so much, Kaliso, and thank you so much to all our speakers for your insights. Unfortunately, we are out of time for our webinar today, but our speakers have been answering some questions that were in the Q&A. We will send a follow-up email in the next few days with answers to some of the questions that were asked in this webinar, as well as a link to the recording for anyone who will be interested in rewatching the webinar. Thank you once again to everyone, to our speakers, for joining and sharing your insights and knowledge in these topics that we covered today. Thank you so much to our attendees for being patient with us in joining this webinar and for just asking the questions and being engaged during the webinar. Thank you so much, everyone. I hope you have a lovely rest of your day, enjoying the rest of World Sexual Health Day, and also just enjoying the early start of our weekend. Thank you, everyone, for joining. Bye.
Thank you, everyone. Bye.
Bye.
Thank you so much. Goodbye.
Thank you, everybody.